as well as curiosity, asking the question, does breast with a cancer have more than one cancer? So we did some whole organ analysis of mastectomy specimens back 20 years ago in Tata Hospital in Mumbai, in which I would do the mastectomy, take it to the freezer, freeze it. After having done the 4 mastectomies of the day, go back to the lab, cut these slices in every 5 millimeters, take x-rays of the slices, take about 20 specimens from every breast, marking in 3 coordinates where these extra specimens were, and then asking the pathologist whether they had tumor or not. And what I found is the new analysis by 3 dimensions was that 2/3 of these breasts who had small cancers had other cancers in the breast. And this is similar to the data from Professor Roland Holland. But the new finding was that 80% of these were in other quadrants. So this was published in 1995 and presented in 1995. And the hypothesis there was that although the diseased breast has many widespread microscopic cancers, more than 90% recurrences occur in other quadrants. So the dormant cancers in other quadrants probably are not the cause of local recurrence. So this, I thought, could be the basis of a clinical trial to give radiotherapy only to the area around the tumor. And the paper was published in 1996 when I came to London to work with Professor Baum. And the idea was that in 3-dimensional analysis, 2/3 of patients have other cancers and 80% of these are in other quadrants. The first part is what I'm going to present in this presentation. And the second part, that most recurrences occur around the tumor, so it makes sense to give radiotherapy only around the tumor, was the basis of the TARGET randomized trial. So it was this academic insight that led to the development of a new device, which is now called IntraBeam, based on precision and immediacy, and this was being tested in the TARGET alone trial. And you probably are familiar with the TARGET-A trial, which was conducted in 33 centers in 11 countries around the world. This was the steering committee, and these are the acknowledgements to all the centers who participated. And you may be familiar with the results. It's recruited between 2000 to 2012, published in the Lancet in 2010, and continued recruitment until 2012, and published last year with the new results of local recurrence and survival. And Lancet put their results on our front page. These are the 3 hypotheses that were tested. Firstly is about local recurrence, that it would be likely to be non-inferior. Second was the biological hypothesis, which I will talk about in today's talk. And third was about mortality of breast cancer and non-breast cancer. So this was the randomized trial. Patients aged more than 45 years of age with unifocal breast cancer. What you need to remember, particularly for this presentation, is that MRI was not required for these patients. Only 5.6% of patients had an MRI. Patients were randomized to receive TARGET versus EBRD in a risk-adapted approach, and the protocol was published in the Lancet in 1999. So these are the most important, most relevant results. This is the test for non-inferiority, which you probably have seen in the published. So we found that TARGET was non-inferior to whole breast radiotherapy for the whole trial, as well as for the pre-pathology when intraoperative radiotherapy was given during lumpectomy. It wasn't found non-inferior when it was given delayed over a course of, on an average, about 37 days. And this is a graph of disease-free survival of the whole trial. And the bottom is over 10 years, although only a few patients are up to 10 years. And you can see that the 2 lines are on top of each other. The 2 strata, that is pre and post pathology, delayed versus immediate TARGET, had 2 different results. Although most patients did very well, non-inferiority was proven for the whole trial as well as when TARGET is given immediately, but not so when it was given as a delayed procedure. So what we found, this is the data from the immediate TARGET, is that there was no significant difference in local recurrence or breast cancer death, but there was a significant difference in non-breast cancer deaths, which I will not go into now. So these are the results for disease-free survival. And this graph, in fact, tells a patient what is her chance of being alive without a local recurrence in the 2 arms of the TARGET trial when TARGET is given during lumpectomy. you can see that the two lines are nearly on top of each other with a probable trend for slightly, you can see 93.9 versus 92.5% survival without local recurrence. For the biological hypothesis, we are trying to go back to the numbers that we talked about earlier. So the trial tested whether giving radiotherapy only to the peritumoral tissues does not jeopardize local recurrence. Now you remember the numbers I pointed out twice before, is that 2/3 of these patients with a cancer will have cancers in other parts of the breast if you analyze their breast carefully. And 80% of these are in other quadrants. And remember, these patients did not have an MRI. So these other cancers would not have been found on an MRI. So we can expect that 63% of 80%, that is 0.8 times 0.63, that's about 50% patients, should have cancers in other quadrants. So let us see the patients in the trial. Concurrent target, that is target during lumpectomy, was given in 803 patients. Expected cancer foci in other quadrants should be present in 50%, that is 405 patients. Breast MRI was done, as I said, only in a few patients, therefore they would not have been excluded. We have 2,777 women years of follow-up. Area around the tumor was radiated in these patients. This is excluding any patient who received whole breast radiotherapy, even as a part of risk adapted radiotherapy. This breast, remaining part, did not get any treatment. What were the recurrences? We had 7 recurrences in the scar, 6 recurrences in the other breast, and 2 recurrences out of the 405 foci in the area which was not treated at all. So the remaining 403 cancer foci over those years of follow-up have not grown. Even in the randomized evidence, the previous data was from a series of patients who were treated. Among randomized evidence, you can see that patients receiving target versus EBRT, the number of recurrences in other quadrants is exactly the same. So that is a QED. Giving targeted intraoperative radiotherapy only around the peritoneal tissues during lumpectomy does not jeopardize local control. And we seem to have a strong support for the hypothesis that is tested in the TARGIT-A trial, supporting partial breast irradiation in general for any type of radiation in a way. Now this is a new graph that we have recently produced. This and the graph of survival without local recurrence, both are published in the Red Journal. It's available online as an accepted manuscript last week. So this is a question that can be asked by a patient. What happened to a woman with early breast cancer treated with target during lumpectomy compared with those receiving EBRT? This is a typical graph of dots representing women. Each dot, one dot is one woman. And you can see that we found no statistically significant difference in either local recurrence or in terms of survival. But you can see that most women are alive, and you can see that how many people are dead. So you can clearly see what might be the difference between the two groups. So that is taking us towards the reality, from vision to reality, is that patients who were suitable for TARGIT-A trial, preferably hormone positive, can receive target alone, and if they are found to have higher risk factors postoperatively, they should have whole breast radiotherapy in about 15 to 20% of patients. And those who we cannot do this, I really would like each and every one of you to consider taking part in the TARGIT-Boost trial. The TARGIT-Boost trial is to test whether giving intraoperative boost is better than giving whole breast radiotherapy, external beam boost postoperatively. That trial is open for recruitment. 20 centers are already participating. So each of you who is interested in IORT, please contact me for taking part in the trial. Target has now been used, I'm told, in 10 to 20,000 women around the world. And our dream really is to make it available to everybody who is suitable. Thank you very much.
Thank you very much, and also for sticking to the time. I can imagine that this is subject of some controversial discussion, at least some of claims wants to start? Yes, please.
Your results of 63% have additional tumor foci agrees with the results published by Holland and his colleagues in 1985 in the Journal of Cancer.
Yes.
However, the 80% of those tumor foci are in the unknown quadrants disagree with his results. In his findings, that most of them, more than 90%, are close to the index lesion.
Yes.
Can you explain this difference?
Yes, I have explained this in our paper published in 1996. The analysis done by Professor Holland was in single dimensions, and he measured the tumor and this distance in linear lines, and he plotted them as 1 centimeter away, 2 centimeter away, 3 centimeter away. And what he found is 90% of tumors are within 3 centimeter of the tumors, which were big. So if you imagine a 3 to 4 centimeter margin around a 3 to 4 centimeter tumor, you get up to 10 centimeters, which is not necessarily much, which is a big portion of the breast. What we did was we analyzed it in 3 dimensions. So for every focus, I had an X, Y, and Z coordinate for every focus of tumor as well as every focus of cancer found. And then I plotted them in 3 dimensions. Then I simulated an excision of the tumor with a margin. And I found that 80% of these other cancers would have been left behind if I had done an excision. So that was the difference in the method of the analysis. And if you use the same method in his study, and I've discussed it with him, he would have got similar results. Thank you.
Next question. Impossible.
Game over.
Then, no. Okay. All the others have their questions put first before me.
Do you have an explanation on why do you think that there were 2 recurrences in the same breast and 6 in the contralateral one?
There were 7 recurrences in the interipsilateral. 9, 7 plus 2, 9.
Right, but 7 were in the same quadrant.
Yes.
2 in the rest of the breast,
Yeah.
as opposed to 6 in the opposite
In the
breast.
whole breast.
Do you have an explanation for that?
I don't know. Maybe some effect that maybe effect of surrounding tissue.
We shouldn't speculate too wildly. It's just
It's a
not
speculation.
A recurrence, it's a second tumor.
Yeah, it's a new
It's
test.
nothing else.
Right, but perhaps the effects that Professor Wentz was talking about are more concentrated in the same breast as opposed to systemically.
That is absolutely possible.
Jay, I have a principal question. The median follow-up of this cohort and this remarkable publications is in the last publication of the whole cohort, still 27 months. And it's very interesting that the same observation which you published, and we quote you, and you're quoted very often with this publication, as well as the work of Holland and Federle, and as well as some colleagues from radiologic departments who showed us in MRI that about the incidence, it's all based on roughly 100 patients we are talking about, all these single observations. But all of them of you show us conclusively that the incidence of out-quadrant foci is higher than expected. And this prompts whole breast radiotherapy, because this is the basis, the hypothesis, why whole breast radiotherapy is necessary to sterilize these foci. So my question is, how long do you think is an observational period necessary in times of huge use of adjuvant treatments which prolong the occurrence of a clinical recurrence within the breast to judge whether the treatment of these foci is necessary or not? My personal belief is that 27 months of a median follow-up in a low-risk cohort who additionally receive adjuvant treatment is not long enough.
There are two ways of answering that. One way is the mathematics of what median means. Now, it may not be condescending to say this, but everybody seems to stick on to median follow-up. Median means 50%. That means half the patients have 2 years, 8 to 6 months follow-up. Less than that. Half the patients have more than that, up to 10 years. So when you say the Elliott trial has a median follow-up of 5 years, we have 1,200 or 1,300 patients who have median follow-up of 5 years. Within the target trial, there are 1,200 patients with a median follow-up of 5 years. Just because we have more patients with a shorter follow-up does not take away what has come from those first 1,222 patients. And the results for those early patients is exactly same as the whole trial. Most events have occurred in those patients. We didn't exclude the later patients. We published everything open and transparent, but that doesn't mean that the longer follow-up, which we already have in the trial, is not there. It is there. So that is what you need to see. It's analyzed in the paper as well. The second point is about how long you need to follow, and that's very interesting. You know, the SEER data set, as well as Kevin Hughes data, where radiotherapy to the whole breast, as well as no radiotherapy has been compared. And you never get 63% recurrence rate in the contralateral, in the breast which is not radiated, even after a very long follow-up. The longest follow-up is in the UBCTCG, where the recurrence rate without radiotherapy after 20 years is 30%. So what happens to other tumors which are there at the breast? It probably don't grow. So we do have longer data that suggests that they are not probably clinically relevant.
The other answer is you overestimate the incidence.
That's possible.
Yeah.
Yeah.
So thank you very much. It would be a brilliant topic to have another 3/4 of an hour of discussion. But due to myself, we are late in time. I apologize for that, and I ask Marco kindly to speed up again. Okay, and give us a talk about intraoperative radiotherapy in breast cancer.